Welcome to ClassMate. I'll help you learn Periodontology I. Right now, as we speak, there is an intense, high-stakes biological battle happening directly inside our own mouths. In this explainer, we're going to visualize this microscopic war zone where our bodies are actively fighting off invading bacteria, and we'll see exactly how modern clinical interventions step in to help us win.
Okay, let's dive into this roadmap. First up, we'll cover Section 1, the periodontal foundation. Then Section 2, the biofilm invasion. Next is Section 3, non-surgical defenses, and we'll wrap up with Section 4, advanced surgery.
Section 1. The periodontal foundation, the structures that support every smile. Imagine we're zooming way down into the 3D structure of the mouth until only the gingiva, the gums, are glowing. Now, the gingiva isn't just some cosmetic frame for your teeth. It is the absolute critical foundation of your oral health. Beneath that visible layer, we've got the periodontal ligament, or PDL. Picture these fibers stretching and bouncing like high-tension bridge cables, literally absorbing the crushing heavy forces of your bite. Then we have the cementum, which acts as the mighty anchor point for those cables. And finally, the alveolar bone. Now, this isn't just static rock. It's a highly dynamic scaffolding that constantly remodels itself based on the health of the surrounding tissue. So where does the trouble actually start? Right here in the gingival sulcus. It's this microscopic, super vulnerable, collar-like space located directly between the tooth surface and the surrounding gum tissue. It might look completely insignificant, but make no mistake, this tiny crevice is exactly the beachhead where the biological invasion begins.
Let's pause for a quick, really crucial myth bust. Does healthy gingiva always bleed when it's brushed or probed? Absolutely not. No way. Healthy tissue is firm, resilient, and it never bleeds during normal clinical probing. Bleeding is literally the biological alarm bell telling us there is active inflammation.
Now, what's really interesting here is this clinical pearl. You'll often hear that healthy gums have a stippled appearance, kind of like the textured skin of an orange. But here's the thing, stippling isn't always present in perfect health. Some patients just naturally don't have it. So as a clinician, you definitely cannot use stippling as your only diagnostic marker. You really have to look at the full picture: color, contour, consistency, and of course, the absence of bleeding.
Section 2. The biofilm invasion, when the periodontium is under attack. When a massive neon green wave of biofilm crashes over a clean tooth surface, the onset of disease is relentless. Within just the first 0 to 24 hours, aerobic plaque forms. But by days 2 to 4, this plaque thickens dramatically. Microbes literally build a complex, 3D, oxygen-deprived skyscraper city, which allows aggressive anaerobic bacteria to absolutely thrive. By weeks 2 to 3, this triggers gingivitis. And if left unchecked for months, we see a dramatic, destructive shift into full-blown periodontitis. Just look at the stark contrast between these two phases. In gingivitis, you've got red, swollen gums, but crucially, there is absolutely no bone loss. The foundation is completely intact. In periodontitis, however, the junctional epithelium physically detaches and migrates down the root of the tooth. And you know what the real tragedy is here? As your immune cells flood the area to fight the bacteria, the collateral damage from your own host response is actually what destroys your dynamic bone scaffolding. Which brings us to a heavy question. Is periodontitis damage reversible? Can we grow that bone back naturally? Unfortunately, no. Bone loss is permanent. Once that foundation is destroyed, it just doesn't regenerate on its own. The fantastic news, however, is that the disease can be arrested, which stabilizes whatever foundation you have left. And that brings us to a critical threshold of clinical detection, the number 4. Imagine dropping a periodontal probe down into that gingival sulcus. The exact second it hits a depth of 4 millimeters, that is a flashing red alert. A 4 millimeter pocket depth is the danger zone. It means the sulcus is now way too deep to clean at home, and an anaerobic environment is actively fostering disease. Section 3. Non-surgical defenses, tactical counterattacks against biofilm. So when that 4 millimeter red alert goes off, we initiate scaling and root planning, or SRP, and we use 2 main weapons for this. Hand instruments give us manual, tactile precision. It's like a highly meticulous carving mission to scrape away hidden subgingival calculus.
Ultrasonic tips, on the other hand, use high-frequency vibration and water. And the clinical pearl here is to always use a very light touch with ultrasonics. You aren't carving with the metal. You're letting the micro vibrations and cavitation bubbles do the heavy lifting to mechanically blast apart that bacterial skyscraper.
Once the battlefield is cleared, we enter the reevaluation phase. You have to wait 4 to 6 weeks for the tissue to shrink, tighten up, and heal. During this healing window, we can also deploy chemical adjuncts. Visualize these as tiny tactical support drones, released right into the deep pockets to target and neutralize any lingering stubborn bacteria while the gums recover. Section 4. Advanced Surgery, High-Tech Interventions for Non-Responders. But what happens when those 4 to 6 weeks are up and those deep pockets are still there? Well, that's when we open the surgical tray. First up, flap surgery. This is literally lifting the gingiva back, kind of like popping the hood of a car, to clearly reveal and remove deep calculus. Next, gingivectomy. This involves precisely trimming away excess fibrotic gum tissue to create a clean contour that the patient can actually manage at home. Then, bone grafting. This is where we place tiny scaffolding particles right into a defect to spark new, local bone growth. And finally, guided tissue regeneration. This uses a physical barrier membrane. Think of it as a cellular bouncer. It keeps the fast-growing soft tissue out so the slow-growing bone actually has the time it needs to rebuild. Seeing all these intense surgical tools might make you wonder, does every single periodontal pocket need surgery? The fact is, absolutely not. Scaling and root planning remains the gold standard for initial therapy. Invasive surgery is strictly reserved for the non-responders. We only use it for the specific sites that refuse to heal after our non-surgical counterattacks. If we do have to proceed with surgery, getting the tissue back together perfectly is everything. As the saying goes, primary closure is the secret sauce for successful regeneration outcomes. Using precise 3D suturing techniques like a simple interrupted stitch, we secure the gingival flaps tightly back into a watertight fit right over the bone. Without that primary closure, the whole healing process is severely compromised. All right, we've looked at the microscopic battles, but let's zoom back out to the big picture. If you watch a patient return from severe inflammation, a bloody, painful mess, back to firm, pink, healthy stability, we have to ask why this matters so much. Well, it matters because oral health is directly tied to a massive global web of systemic conditions. The inflammatory burden of periodontitis doesn't just stay magically confined to your gums. Those inflammatory markers enter your bloodstream, and they heavily influence systemic conditions like heart disease. So, I'll leave you with this final thought to ponder. If the microscopic battle taking place inside your gums can directly affect the health of your heart, what other hidden biological wars are shaping your overall health right this very second? Thank you for choosing ClassMate. See you in the next lesson.